Al-Fatiha. Okay, again, Assalamualaikum warahmatullahi wabarakatuh and a very good morning. I bid to our lecturer, Dr. Muhammad Faiz and my fellow friends. So today is our seminars entitled Deliriums and Dementia. Okay, so this is our outlines of presentations. We'll start with delirium first and then followed by dementia. So before that, my name is Cik Muhammad Alif bin Sheikh Ghani, matric number 1717001. So I will be the first presenter, and then we'll explain about introductions, epidemiology, clinical features, and also risk factors of delirium. So as for the introduction of delirium, so according to our textbook, Kaplans and Sadoks, the delirium is characterized by an acute decline in both the level of consciousness and cognitions with particular impairment in attention. Whereas in DSM-5, the definitions of delirium is more precise because it also includes the characteristics of this syndrome. So delirium is a disturbance in level of awareness or attention marked by the acute or subacute onsets of cognitive changes attributable to a general medical conditions. It tends to have an acute onset, relatively brief durations and fluctuating course. So what the most important point that we must extract from the definition itself is delirium is an acute mental state changes that attack the consciousness and cognitive level or cognitive functions, and this condition is caused by other medical illness. And then from the textbook itself, from the textbooks of Kaplans and Sadoks, deliriums also, there's other names of deliriums stated, for example, like intensive care unit psychosis, acute confusional states, acute brain failures, encephalitis, encephalopathies, and CNS toxicity. Okay, so next we go to the epidemiology. This epidemiology also extracted from our textbook. So delirium is a common disorder with most incidence and prevalent rates reported in elderly adults. So in a community, in a group of elderly person that age more than 55 years old, 1% of them will have delirium as compared to the group of age more than 85 years old will have the prevalence of delirium with 13%. In the hospital setting, the patients, elderly patients that go to the emergency department, around 5 to 10% will meet the criteria of delirium. At the times of admission, compared to at the times of admission to the medical ward, which range from 15 to 21%. As for the post-operative delirium, following the orthopedic surgical is higher prevalent, which is more than 50% is if compared to open heart surgery, which is 30%, and general surgical patient, which is range from 10 to 15%. In intensive care units, the prevalence of delirium is also high, which is 87%, which may reach to 87%. And then patients at the ends of life care also have high prevalence of delirium, which is 83%. So after all, why it is important to know delirium? This is because the mortality rates of delirium itself is high. For example, like for the patient who have an episodes of delirium, which is in periods of 3 months, the mortality rate is 23% to 33%. Whereas in 1 year episodes of delirium, the mortality rate may reach as high as 50%. Elderly who experience delirium while hospitalized, the mortality rates also may reach up to 75%. So after the patient discharged, in a periods of 1 month, the prevalence of death is 15%. And also in 6 months of periods after discharge, the prevalence of death is 25%. So what we can conclude from the mortality rates, the delirium itself is what we can conclude from these mortality rates. Delirium has poor prognostic signs. Okay, next we go to the risk factor. So basically risk factors of deliriums, we can divide into predisposing factors and precipitating factor. Predisposing factor is the factors that render the individual vulnerable to these syndromes, delirium. So for example, like age more than 65 years old, male, cognitive status like dementia, cognitive impairment, depressions, functional status like immobility, functional dependence, sensory impairments like hearing, visual, and decreased oral intake that lead to dehydrations and malnutrition. Then there's certain drugs, for example, like psychoactive drugs and anticholinergic drugs, and also alcohol abuse. Certain coexisting medical conditions like chronic renal or hepatic disease, stroke, neurological disease also can predispose patients to develop delirium. On the other hand, the precipitating factors, this precipitating factor is factor that triggers the patient to have these uh, syndromes or deliriums. So for example, like certain drug, for example, like sedative hypnotics, anticholinergic drugs, treatment with multiple drugs, and alcohol or drug withdrawal. The primary neurological disease also can cause delirium, precipitate to cause delirium. For example, like stroke, intracranial bleedings, infection, meningitis or encephalitis, intercurrent illness, infections, for example, like pneumonia, hypoxia, shock, dehydrations, and certain surgical procedure, for example, like orthopedic surgery or cardiac surgery. And environmental also plays an important role to cause delirium to be happen. So it is important to know the factors that trigger the delirium to be occur. This is because delirium itself, it is a reversible syndrome. So our main target for the management is to identify and then identifies and treat the factors in order to reverse back the functions to be normal. So next we go to the pathophysiology. So basically pathophysiologies pathophysiologies of the delirium is still not fully understood. However, in the Medscape, it is stated that mechanism of deliriums is caused by varieties of structures or physiological insult. As a part of physiological insult, the main point is about neurotransmitter imbalance. So major neurotransmitter hypothesis to be involved in delirium is acetylcholines. So other than acetylcholines, the other neurotransmitter that can be involved is, for example, like GABA, dopamines, glutamates, and serotonin. And this imbalance of neurotransmitter is caused by other causes, for example, like medical condition, for example, like hepatic failure, certain drugs, benzodiazepines, and also certain substance, for example, like alcohol. So as a part of structural mechanism, so the structure that mainly involved in delirium, developments of deliriums is reticulum formations. It is because these parts of reticulum formations is the 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 parts that mainly function for arousals and attention. So if any insult of this part, it will lead to deliriums. And then other than that, disruptions of blood-brain barriers also can cause delirium to be occur. This is because when this barrier is disrupted, it will allow neurotoxics and also inflammatory cell to enter in the brains and also lead to deliriums. So next we go to the clinical features of delirium. So the core features of the deliriums is we have two core features of deliriums, which are altered consciousness and impairments in cognitive functions. Altered consciousness is the patients might presented with decreased levels of consciousness or altered attention, which can include diminished ability to focus, sustain or shift attentions. And in impairments in cognitive function, patients might have disorientations, especially to the time and space, and also decreased memory. Despite of the core features, the other associated symptoms, for example, like disorganizations of thought process, which also we can assess through the speech of the patient. For example, like patients have incoherent types of speech, and also these and also perceptual disturbance. Also, for example, like illusions or hallucinations might be presented. And then psychomotor and hyperactivity, for example, psychomotor hyperactivity, for example, like agitations or restlessness, or hypoactivity, for example, like slow motor functions and lack of responsiveness, also might be presented. So other than that, the disruptions of sleep-wake cycle, for example, like patient complains of frequent awake during sleeps, with or without daytime somnolence, and then more alterations and also altered neurological function, for example, like instability and dysarthria. So after all, for these clinical features of deliriums, the delirium has classical characteristic for the clinical features. For example, like sudden onset, the clinical features is sudden onset in nature. It is between hours or days, and then a brief and fluctuating course and rapid improvement when the causative factor is identified and eliminated. So I think that's all for my part. I will pass to Nik Akmal for further explanations regarding delirium.
Bismillahirrahmanirrahim. Thank you, Cik Alif. Now we're moving to diagnosis of delirium. So usually, delirium can be diagnosed at bedside as it is a clinical diagnosis, and the component that can help us in the diagnosis of delirium and also to identify the causes of delirium is the history, physical examination involving the mental status examination and also the mini-mental state examinations. And the last one is laboratory and imaging. For lab and imaging, it is basically to identify the underlying causes of delirium. Next. Now for diagnostic criteria, according to DSM-5, there are 5 criteria. The first is there must be a disturbances in terms of attention and also awareness of the patients. The patients may be presented with reduced ability to direct, focus, sustain, and also shift attention. In term of awareness, they may have a reduced or poor orientation to the environment. For the second criteria, in terms of duration, the disturbances develop over a short period of time and the severity tend to fluctuate during the course of a day. And the third criteria, besides from disturbances in attention and awareness, there must be an additional disturbances in terms of the cognitive function of the patients. So they may be presented with memory deficit, disorientations, or perception. For the fourth criteria, the disturbances are not better explained by another pre-existing, established, or evolving neurocognitive disorder, and it does not occur in patients with severely reduced level of arousal, such as in comatose patient. For the fifth criteria, there must be evidence from either the history, physical examination, or laboratory findings that support the disturbances is due to the direct physiological consequences of another medical condition, substance intoxication or withdrawal, exposure to a toxin, or even due to multiple etiology. And then we need to specify the delirium, whether it is a substance intoxication or substance withdrawal, medication-induced delirium due to another medical condition, or it is due to multiple etiology. And we need to also specify if it is acute, lasting few hours or days, or persistent delirium, lasting weeks or months. In regards of the psychomotor activity, it can be specified to hyperactive, hypoactive, or mixed level of activity. For hyperactive delirium, the patients usually accompanied with mood lability, agitations, or refusal to cooperate with medical care. For hypoactive psychomotor activity, they may be presented with sluggishness and also lethargy. For the mixed level, it is a mixed level of hyperactive and hypoactive. Next. Now we're moving to physical examinations. For physical examination, I've included the possible findings that may be found during the physical examinations according to different underlying medical conditions. So basically, we need to tally our physical examination with the history taking that we have obtained. So I think you can read it on your own. So the physical examination also often reveals the clues to the cause of delirium. Next. So it's for MSE and MMSE. We usually use MSE. For MMSE, it is not to diagnose delirium, but it is more to help us in assessing the cognitive function. And usually we do it during the clinical follow-up because we want to assess the improvement of the patients. For MSE, among the symptoms in delirium is in regard to disturbance of the memory, poor attention and also orientations. In terms of sensorium, the patient may be presented with hallucination, especially the visual hallucinations, and impaired in thought content and also judgment. For MMSE, the cutoff value is 24 out of 30. So if the patient scored below than 24, it may indicate the patient is having cognitive impairment. Next. For lab workup, it includes the standard studies and also additional tests. So basically, we do the standard studies first, and if indicated, then we do the additional tests. It is the same as physical examination to identify the causes of delirium, and we need to tally it with the finding from the history and also physical examination. We didn't order all of these tests in a single delirium patient. For standard studies, the first is blood chemistry or blood test to look for the electrolyte imbalance such as hypocalcemia or hyponatremia, renal function test, and also liver function test to look for renal failure and also liver failure. And lastly, the blood glucose level for hypoglycemia or hyperglycemia indicating DKA. The next is full blood count to look for sign of anemia or infections, thyroid function test for thyroid problem, serology test for syphilis, HIV antibody test, urinalysis to look for sign of UTI, ECG, sign of heart failure such as arrhythmia. For electroencephalogram, the EEG, it is said to be done in patients that we are suspecting a seizure or we are unclear of the causes of the delirium. For chest x-ray to look for sign of heart failure and also pneumonia, infections of the lung, and blood and urine drug screen for toxicology test. For additional tests, it includes the blood, urine, and also CSF culture, sign for infections, B12 and folic acid concentration to look for their deficiency, or MRI of the brain if the patient's presented with new focal neurological deficit or has history of head trauma, and then lumbar puncture and CSF examination to look for sign of CNS infection. Next. Okay. Moving to management of delirium, we need to remember the primary goal in managing delirium is to treat the underlying causes because it is usually correctable and reversible, and if it is left untreated, it is said to be associated with high mortality rate, serious medical complication, and also irreversible cognitive impairment. So the other goal is to provide support in terms of physical, sensory, and emotional. We need to avoid physical restraint in delirious patients because they may be feeling fear and agitated, so they may act aggressively. In terms of sensory, if there is disturbances or impaired visual or hearing, then we may need to provide them with hearing aid or eyeglasses. For environment, we need to provide stable, quiet, and also adequate lighting. And the patients may need a familiar person to be with them and to help them in terms of orientation. And we can provide them with cloth and calendar. For pharmacological treatment, our main is to treat the psychosis, agitation, and also insomnia. For psychosis and agitation, we used antipsychotic agent, and for insomnia, we can use benzodiazepine. I'll explain later. However, we need to avoid sedation unless in severely agitated or necessary for us to minimize the risk to the patients or facilitate investigation and also treatment. After that, we will do MMSE, regular MMSE, to monitor the cognitive functions during the patient's follow-up. Next. These are the choices of drugs for the pharmacological agent. The first is typical antipsychotic. It is the most commonly used drug in clinical practice. However, it is said to be associated with extra pyramidal side effects and prolonged QT interval. For atypical antipsychotic, it has less extra pyramidal side effects, but still can prolong QT interval. And from what I've read, although atypical is associated with lower or lesser extra pyramidal side effect, EPS, but it is not as common as haloperidol because of its limited clinical use in the management of delirium. For benzodiazepine, it is best used in delirium that occurs secondary to alcohol or benzodiazepine withdrawal. We didn't prescribe lorazepam to all patients with delirium because of its side effect, which is the respiratory depression and also paradoxical agitations. So we only prescribe them in delirious patients, in delirious patients secondary to alcohol or benzodiazepine. And for your information, for antipsychotic, if you are prescribing antipsychotic to the patients, we need to always uh, monitor the patients for their side effects, and because if it is used for long term, it can cause metabolic syndrome, where it will increase the risk for type 2 diabetes mellitus, hyperlipidemia, and also can cause weight gain in the patient. And if it is given to all the patient with dementia-related psychosis, it even has a higher risk for stroke and also death. Next. For treatment in special population, which is the patients with Parkinson's disease, the delirium is caused by anti-Parkinsonian agent. So for the treatment, we need to decrease the dosage of the agent first. If we are unable to decrease the dosage, or if we have already decreased the dosage but still the symptoms persist, then we can start to give antipsychotic. We didn't start antipsychotic agent directly because of its side effect, the extra pyramidal side effects, where it can cause the Parkinsonism features. So this may worsen the condition. So we always need to review back the dosage and also the prescribed medication in this group of patients. Next. I think this is all for the Lilas.
Okay. So next we proceed with dementia. Next. We have divided dementia into three parts, which is the first part. I will be presenting about the first part, introduction, risk factors, clinical features and differences. And the second and third will be presented by my colleagues, which is about subtypes, etiology, and also assessment and management of the dementia. Next. So before we go deep through dementia, according to Kaplan and Zadok's, dementia could be defined as a disease process marked by progressive cognitive impairment in clear consciousness. So here, next. Here I would like to highlight the three main key points. The three main key points in this definition, which is the first one is progressive. Dementia is a progressive disease, and then it should have a decline from a previous level of functioning. Therefore, low intellectual functioning and also mental retardation is excluded from this because it is a developmental and a static condition. So the second key point is that it have a cognitive impairment, as I will be discuss about it later. And the third point is clear consciousness. So these differentiate between dementia and delirium, because dementia patient will have a clear consciousness, while a delirium patient will have an altered consciousness. So dementia in the NCF5 is referred as the major neurocognitive disorder, or in a less severe form, it will be referred as mild neurocognitive disorder. Next. So this table are listed in the SM5 are about the 6 neurocognitive domains that can be affected in a dementia patient. So in this table, the SM5 have listed the examples of symptoms and also the example of assessment for each of these six neurocognitive domains. So I will not go through in details, but hope you can read it later on. So the first, I just highlight the domains, which is the first one is the complex attention, because dementia patient will have an impact in attention, such as difficulty in attention to give attention in environment that have multiple stimuli, such as sound of conversations, radio, and TV simultaneously. And then dementia also, patient also will have reduce in processing speed, so they have thinking. They will think. Their thinking period will have a longer duration than normal. And then second neurocognitive domain is the executive function. So this involves planning, decision making, and also working memory. Next. So the third neurocognitive domains is learning and memory. So usually the recent memory is the most impact one, the most early and impact one. And then in severe form of dementia, long-term memory might be impact as well. So the fourth one is language. So language involves the expressive language and also the receptive language. So dementia patient might use general phrases such as that thing or you know what I mean. So next, the fifth cognitive domain is perceptual motor, which includes visual perception, visual constructional, perceptual motor, praxis, and gnosis. And the last one is social cognition. So therefore, they cannot recognize any emotions or theory of mind. Next. So the epidemiology of dementia, because we know that currently our population are shifting towards more aging population. So the prevalence of dementia is also rising. So in dementia, about 50 to 60% of patients with dementia having an Alzheimer's disease type. And then female are more have a higher rates compared to male to get this Alzheimer's disease. And then 15 to 30% of dementia patients have a vascular dementia, and this is higher in male compared to female. And then 10 to 50% have coexisting between vascular dementia and Alzheimer's disease. And about 1 to 5% have other type of dementia, such as HIV dementia, head trauma, and others. Next. So these are the risk factors for dementia. According to CPG, it could be divided into non-modifiable and potentially modifiable. So the first for non-modifiable is age. Prevalence of dementia doubles for every 4 to 5 years after the age of 65 years. And second one is gender. Prevalence study shows that higher rates in female compared to male. But in vascular disease, have mentioned earlier, male is more compared to female. The third one is genetics. There are three causative genetic mutations that have been known, which is the first one is amyloid beta protein precursor, and second is presenilin 1 and also presenilin 2. But there is no genetic mutation has been identified for late onset Alzheimer's disease. Most likely genetic will cause an early onset of Alzheimer's disease. So early onset here means that an patient get Alzheimer's disease before the age of 60 years. So next, the fourth one is intellectual disability and Down syndrome. So this kind of population will have a much higher rate to get dementia compared to the normal population. So next is the potentially modifiable, which is CPG have classified into three, which is cardiovascular risk factor such as hypertension, hypercholesterolemia, diabetes mellitus, folate, and high homocysteine level. Second one is lifestyle risk factors, which is obesity, alcohol use, smoking, head injury, physical activity, and education stimulation. So these two um, are more predisposed to vascular dementia, because vascular dementia, because these risk factors will lead to atherosclerosis and um, and then proceed with cerebrovascular accident and then leads to vascular dementia. So the third one is medication. So studies have shown that NSAIDs, statins, and antioxidants are actually protective towards dementia, but research shows that it should not be used to prevent dementia because the risks outweigh the benefit. So next. So these are the clinical features for dementia. The first one is memory impairment, which is the most prominent early symptoms. Um, so in early, usually it is mild. The memory impact is mild, usually most marked for recent events such as dementia patient will have forgetfulness in recent conversation or events of the day. And then as disease progress, this memory impairment will become severe and then will lead to can also impair orientation, which is oriented to time, place, and persons. So for example, patient with dementia may forget how to get back to the room after going to the bathroom. But I would like to highlight here, even though the memory impairment is severe enough, but the level of consciousness is still intact. And then next is mood. They will have a mood lability, depression, and anxiety. Next is personality changes. They will become more introverted, less concerned than before, and then become more irritable and explosive. This irritable and explosive is actually very disturbing, especially towards the caretaker of the dementia patient. And the next is hallucination and delusion. The most common delusion is persecutory delusions. And the next is language. Dementia patient will have difficulties in naming, word finding, and become less spontaneous, and will have less spontaneous speech. And for other clinical features, they will have poor judgment, and then so we could see that dementia patient will do an inappropriate jokes, also have social withdrawal, sloppy grooming, dull apathetic facial expressions, and sometimes they will have seizures, and then they also will have apraxia, which is inability to perform learn or familiar movements such as brushing teeth or button shirt. Also have agnosia, which is loss of ability to recognize and understand information from sense. So usually the most common example is that they are unable to recognize familiar faces, as for example, the family members, especially the distant ones such as grandson. And then other is reduced abstraction. Okay, for other neurological signs that might suggest for vascular dementia is apa ni? They are usually the sign and symptoms of stroke. For example, dizziness, weakness, dysarthria, and headache. Next. So these are the diagnostic criteria that have listed in DSM, which DSM have listed major and minor neurocognitive disorder. So we go through a little. And then first, for A, there is evidence of significant cognitive decline from a previous level in one or more cognitive domains. So these are based on concern of the individual itself or from a knowledgeable informant such as the family members or the clinician that there is a significant decline in cognitive function. Second, it could be based from the substantial impairment in cognitive performance, which documented by neuropsychological testing. And B, is the cognitive deficits interfere with independence in everyday activities. For example, they might require assistance with complex instrumental activities such as in paying bills or manage medications. So this B part is actually what differentiate between major and mild neurocognitive disorder, because in mild neurocognitive disorder, they are not interfere with independence. Maksudnya they not required any assistance to do the complex instrumental activities. And then for C, not occur exclusively in context of delirium, and D is not better explained by any other mental disorder. And then we also need to specify the etiologies. I believe that the next presenter will talk about that. And then also need to specify with or without behavioral disturbance. For example, any psychotic symptoms, mood disturbance, agitation, and also need to specify the severity of this dementia, which is mild, this severity is based on the functionality, which is mild difficulties with instrumental activities, and a moderate with basic activities such as feeding, and a severe is fully dependent towards the assistance. Next. So this is the moral from the DSM-5. Yeah. So I will not repeat again. Next. So the last part is the difference between dementia, delirium, and depressions. Sometimes some books use depression referred also as pseudo-dementia or depression-related cognitive dysfunction. So the major difference here is the first one is the onset of the disease. So dementia usually have an insidious and gradual onset of symptoms, signs and symptoms, which usually takes months or even years for the symptoms and signs and symptoms to progress. And then for depression, usually gradual, but it takes weeks or months. But delirium is acute, which is within hours or days and even weeks. And then for course, usually it's gradually progressive, so it's much more stable over time. Sometimes the patient or the people surrounding them are not even notice that the patient is actually having dementia. And the next is depression. The cause is worse in morning, but improve as the days goes by, and improve towards the night. For delirium, the signs and symptoms fluctuates, but usually worsen at night. And then for alertness, dementia patient usually alert, but delirium patient have a reduced consciousness. And then the others, I would like you to read by on your free time. Next. So these are other tables regarding delirium and dementia from Kaplan and Sadok's. Also, I will not read about that. Next. So these are also difference between clinical features between depressions and dementia from Kaplan and Sadok's. So yeah, that's next. I'll pass to the next presenter.
Okay, Assalamualaikum. My name is Nusalwa Shaira binti Muhammad Fuad. I will continue the presentation with etiologies and subtypes of dementia. Next. This is the list of possible etiologies of dementia, and it can be divided into several categories. And the first one is degenerative dementia, such as Alzheimer's disease, frontotemporal dementia, or peak disease, Parkinson disease, and Lewy body dementia. And then dementia can also be caused by vascular problem. And for degenerative and vascular dementia, I will further explain after this. And the next etiologies of dementia is infection, such as HIV infection, because encephalopathy in HIV infection is associated with dementia. Next is prion disease. So in our brain, there is presence of prion protein. And in prion disease, it is a condition when the prion protein become abnormally folded that will cause brain damage. Next infection is syphilis that can also cause dementia. And then dementia can also be due to head trauma. And then it can also be caused by Huntington disease. So Huntington disease is a rare inherited disease that will cause progressive degeneration of nerve cells in the brain. And Huntington disease is a subcortical type of dementia. So it is characterized by more motor abnormalities and fewer language abnormalities compared to the cortical type of dementia. So patients with Huntington disease, they will have psychomotor slowing and difficulty with complex tasks, but the memory, language, and insight will remain intact in the early and middle stage of the illness. However, when the disease progresses, so dementia will become complete. And then dementia can also be due to psychiatric problem, such as pseudo-dementia of depression. Next, dementia can also be due to physiological problems, such as hydrocephalus. And then can also be due to metabolic disease, such as vitamin B12 and folate deficiencies, hypothyroidism, and also uremia. And then tumor, either primary or metastatic, can also cause dementia. And then demyelinating disease such as multiple sclerosis, and lastly drugs and toxin. So alcohol and other heavy metals can also cause dementia, and then some medication such as anticholinergic can also cause pseudo dementia. Next. Then we go to the subtypes of dementia. So there are 5 common subtypes based on the etiologies of dementia. I will explain one by one. Next. Okay, we go to the first one, which is dementia of the Alzheimer's type, or we usually call Alzheimer's disease. And it is the most common type of primary degenerative dementia, and it accounts for 60 to 80% of cases. And Alzheimer's disease usually characterized by progressive deterioration of short-term memory and other higher cortical function. However, the motor skill will be preserved until late in the disease. And the supportive features of Alzheimer's disease are altered behavior and inability to carry out activities of daily living. And Alzheimer's disease usually affect the older age group, which is more than 65 years old. And for the cause of the dementia of the Alzheimer type remain unknown, but some studies stated that about 40% of patients have a family history of dementia of Alzheimer's type. So because of that, genetic factors are presumed to play a part in the development of the disease. And there is an additional support to support the genetic factor because they found that the rate for monozygotic twin is higher compared to dizygotic twin. And the cause of the Alzheimer's disease is associated with the amyloid precursor protein, which is located in the long arm of chromosome 21. And one of the breakdown product of the amyloid precursor protein is beta-A4 protein, which is the major constituent of senile plaques. So when there is a pathological or abnormal process of the amyloid precursor protein, so it will cause excessive production or deposition of the beta-A4 protein that will lead to dementia. And then one study also found that multiple E4 gene is associated with Alzheimer's disease. However, they found that people without dementia also have this type of gene, and not all cases of dementia is associated with E4 gene. Because of that, diagnostic testing for E4 gene is not currently recommended. Next. Okay, then we go to the neuropathology. So in Alzheimer's disease, so gross neuroanatomical observation of the brain, we can see there is a diffuse atrophy with flattened cortical sulci and enlarged cerebral ventricles. And for the microscopic finding, we can see there is a presence of senile plaque, or also known as amyloid plaque. And the presence of senile plaque or amyloid plaque more strongly indicates Alzheimer's disease. Then we can also see neurofibrillary tangles, which compose of phosphorylated tau protein. However, they are not unique to Alzheimer's disease because they can also be found in other diseases such as Down syndrome. And they usually found in the cortex, hippocampus, substantia nigra, and also locus coeruleus. And then we can also see there is presence of neuronal loss, particularly in the cortex and hippocampus, synaptic loss, and also granulovascular degeneration of the neurons. Next. Okay, now for the neurotransmitter. So neurotransmitter that usually implicated in the pathophysiological condition of Alzheimer's disease are acetylcholine and also norepinephrine. And both of them are hypothesized to be hypoactive in Alzheimer's disease. So decreased acetylcholine is due to cholinergic deficit. So when there is a reduction in the number of cholinergic neuron, so choline acetyltransferase will be reduced. So we know that choline acetyltransferase is the key enzyme for the acetylcholine synthesis. So when choline acetyltransferase reduced, so acetylcholine synthesis will also be reduced. And then they also observe the presence of cholinergic antagonists such as scopolamine and atropine can impair the cognitive abilities, while the cholinergic agonists such as physostigmine and ericoline will enhance the cognitive abilities. And then for decreased norepinephrine activity is due to decrease in norepinephrine containing neurons in the locus coeruleus. And the other two neurotransmitter that also contribute to the pathophysiological condition of the Alzheimer disease is somatostatin and also corticotropin, and both of them are also be found to be decreased in Alzheimer disease. And then we go to the other causes of dementia of the Alzheimer type. And some theories said that abnormality in the regulation of membrane phospholipid metabolism can also cause Alzheimer disease, because when there is abnormality in the metabolism, it will make the membrane become contain less fluid, so it make the membrane become more rigid compared to the normal one. And then aluminum toxicity, however, it is no longer considered as a significant etiological factor. And then some also thought that excessive stimulation by the transmitter glutamate can also cause neuron damage. Next. Okay, then we go to the familiar multiple system topathy with presenile dementia. So this disease have contain similarities with the Alzheimer's disease, and the gene for the disease is carried on chromosome 17. And patient with the disease will usually have short-term memory problem and difficulty to maintain balance and walking. And the onset of disease usually occur in 40 and 50 years of age. And the person with the disease will live an average of 11 years after the onset of symptom. And in this disease, it's similar like Alzheimer. There is a buildup of the tau protein in the neuron and glia cells that will kill the brain cells. However, in this disease, it is not associated with the senile plaque such like Alzheimer disease. Okay, next. Okay, we go to the second subtype of subtype of dementia, which is vascular dementia. And before this, vascular dementia known as multi-impact dementia. And the primary cause of vascular dementia is multiple areas of cerebral vascular disease that will result in symptom of dementia. And usually, it is common in men, especially those with pre-existing hypertension or other cardiovascular risk factor. And it will affect primarily small and medium-sized cerebral vessels, which undergo infarction and produce multiple parenchymal lesion over the brain. And the causes of the infection can be due to occlusion of the vessels by the atherosclerotic plaque or thromboemboli from the distant origin, such as heart valve. So upon examination, we can see there is a carotid breach, phaneoscopic abnormalities, or enlarged cardiac chambers. And then there is a disease which is Binswanger disease, or known as the subcortical atherosclerotic encephalopathy, which that can also contribute to vascular dementia. So Binswanger disease is characterized by the presence of many small infarction of the white matter, but spare the cortical region. Okay, next. Okay, then we go to the third subtypes of dementia, which is frontotemporal dementia, or known as Pick's disease. So it is characterized by a preponderance of atrophy in the frontotemporal region. And in the region, we can also find there is neuronal loss, gliosis, and peak bodies. So peak bodies is a masses of cytoskeletal element. But the cause of Pick's disease is unknown, and it constitutes approximately 5% of all irreversible dementia. And usually it occurs in men, especially those who have a first degree relative with this condition. And the onset is less than 75 years of age, and even the more younger can occur. And in peak disease, in early stage, there will be personality and behavioral changes. However, there will be a relative preservation of other cognitive function. And then the features that can differentiate Alzheimer disease from the peak disease is in peak disease, a patient usually have social misconduct, hyperorality or akinesia, and absence of perceptual disturbance. But in peak disease, the memory usually not predominantly affected. Next. Then we go to the dementia with Lewy body. So in this subtype, so the Lewy body inclusion is found in the cerebral cortex, and it is characterized by hallucination, Parkinsonian features, and also extrapyramidal sign. And this is the clinical criteria for dementia with Lewy bodies. And for probable dementia Lewy bodies, it requires 2 or more core symptoms, whereas for possible dementia with Lewy bodies only require 1 core symptom. And for the core features, such as fluctuating levels of attention and alertness, recurrent visual hallucination, and Parkinsonian features such as cartwheeling, bradykinesia, and also resting tremor. While for the supporting features for dementia with Lewy bodies, such as repeated falls, syncope, sensitivity to neuroleptic, systematized delusion, and also hallucination in other modalities. And then how we want to differentiate dementia with Lewy bodies from Alzheimer's disease. So basically, patients with dementia with Lewy bodies, they tend to have more problem with executive function, such as in planning, prioritizing, and also sequencing, as well as visual spatial impairment. However, they tend to perform better with verbal memory. Okay, next. Okay, next we go to the fifth subtype of dementia, which is Parkinson disease. So it is a disease of basal ganglia, commonly associated with dementia and also depression. And the Lewy bodies usually mainly found in substantia nigra. And about 20 to 30% of patients with Parkinson disease will have the dementia. And patients with Parkinson disease will have slow movement and features of bradyphrenia, such as slow thinking. And then I want to add in dementia, it can be also mixed dementia. So for example, it can be coexisting of the Alzheimer disease with the vascular dementia. And then so we already go through all 5 subtypes of dementia. So from all the 5 subtypes, the most common is Alzheimer disease, and then followed by vascular and other subtypes of dementia. I think that's all from me. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. So I will be the last presenter for today's seminar, and I'll be continue with the assessment and management of dementia. So dementia, as many other conditions, is assessed by taking a detailed history, performing physical examination and investigation. As dementia is diagnosed clinically, for that physical examination and investigation we do is to support the diagnosis and for further classifying the type of dementia and that the patient has, and to identify any reversible causes of dementia. Next slide. So in the history, basically the history will be taken from either the patient or the patient's family, friends, or employers, as history from a reliable informant is mandatory. And if there are any history suggestive of personality changes in a 40 years old individual, we should consider dementia as one of the possible causes. And in the history, we need to ask the patient on the clinical features of dementia and to rule it out from the other depression diagnosis. So the feature of dementia has been explained by my friend before, which consists of the cognitive and non-cognitive symptoms of dementia. And other than that, we also need to ask about the activity of daily living of the patient and to know if there are any impairment or declining in the patient's capability to perform their daily function. We need to ask about the onset, the cause of disease, and the severity of the symptoms. Other symptoms that we will also like to ask would be the psychological and neurological symptoms, because certain subtypes of dementia can present with certain psychological and neurological symptoms. The symptoms include changes in the personality, hallucination, mood changes, and catastrophic reaction, in which personality changes will be more prominent in the frontotemporal dementia. The next slide. So these are a few cognitive domain with questions that we can use to ask in the patient, to the patient, as stated in the DSM-4 criteria to diagnose dementia, in which we need to assess for the presence of amnesia in the patient and to note of any other declines of other following domains, which is the aphasia, apraxia, anosmia, executive function, and also to know of the severity of the domains affecting the patient life. So next slide. Next is the critical examination. So generally, when the doctors first see the patient, they may present with a smoky grooming and maybe in an unhygienic state. So apart from that, it is important to do a general system examination in this case, since dementia can be caused by various kinds of pathology. Thus, this might reveal any underlying causes of brain dysfunction other than the neurodegenerative cause, such as the finding of hepatomegaly or signs suggestive of hepatic encephalopathy. And to note, any sign of kyphosis sarcoma, such as the thin lesion that occur in this condition, will suggestive towards an HIV-related dementia, with the support from the history. So in neurological examination, one should note of any proper neurological signs, which include the asymmetrical hyperreflexia, weaknesses of awareness, which may suggest an upper motor neuron lesion, and any sign of Parkinsonism, which is the bradykinesia, resting tremor, and the cogwheel rigidity, which may present in the dementia of ubiquity. Next is to do a cognitive test, in which we use the mini mental state examination to assess the patient cognitive function and the severity of the cognitive impairment. So this MMSE is done based on the cutoff value point, and if if the total score is lesser, it will be suggestive of cognitive impairment, and the severity would range from mild, moderate severe, and severe cognitive impairment, which will be used in the management later on. In next slide. The previous slide is the Malay version of and then this is the English version. The next slide. For the investigation, we do the investigation based on the history, the examination, and the mental state examination result. So one should be evaluated for the causes of dementia, as some may be of reversible causes. And in order to provide the family and patient with a definitive diagnosis of what actually causing the patient to have this condition. So in blood test, for blood count and erythrocyte sedimentation rate is the only routine investigation done in dementia, with addition of other lab tests such as electrolyte, calcium, glucose, and renal and liver function, and also thyroid function test and serum vitamin B plus and folate levels to evaluate for the reversible causes of dementia, as in cases of hypothyroid and deficiency in vitamin B plus. The next is the imaging. Imaging, we can use if there's an indication to do the neuroimaging test. If there are historical feature or finding pointing toward an intracranial pathology, either through structural or functional imaging. Structural imaging, such as CT scan and MRI, is used to rule out any intracerebral pathology and to aid in determining the subtype of dementia. Then goes to the functional imaging, which one of the example is the PET scan. So other tests would be the EEG, electroencephalogram, and the biomarkers, which only be indicated in a certain situation of patient. So next slide. So we move to the management of dementia. So management of dementia can be divided into non-pharmacological and pharmacological intervention. So the first line approach, as stated in the signature of dementia, is the non-pharmacological intervention, which consists of the psychosocial intervention. Next slide. So the aim of the management is actually mainly for the maintenance of function, which involve in adopting activities to promote independence and maintenance of patient cognitive function. This intervention will be altered by the individual's need and require a multidimensional approach to ensure the effectiveness of the intervention. So next slide. The activities include the communication strategies, the ADLC training, assistive technology, exercise to promote mobility, rehabilitation program, and a combination of all the interventions. Next slide. And for the maintenance of cognitive function, there are actually three approaches that could be done, which are the cognitive-oriented approach, relative orientation therapy, and reminiscent therapy or life review, in which the basis of this therapy is to stimulate the cognitive function in order to improve it. Okay, next slide. The next is the pharmacological management of dementia. This pharmacological management should be used in conjunction with the psychosocial intervention in order to improve the patient cognition, function, and behavior. And pharmacological intervention treatment should only be initiated by specialists in the care of dementia, which consists of the psychiatrists, neurologists, and geriatricians. In condition with comorbid, such as in Alzheimer's disease and vascular dementia, which has which commonly presented with vascular risk factor, it is appropriate. It is appropriate for the doctor to ensure the appropriate level of control of the comorbid, as this may benefit in halting the progression of the disease. Next, based on the severity of dementia, as mentioned before, in cases with mild to moderate Alzheimer's disease and vascular dementia, acetylcholinesterase inhibitors such as donazepam, rivastigmine, and galantamine may be beneficial in improving cognitive function. And donazepam is highly recommended as the other two has GI side effects. While in cases of moderately severe to severe dementia, a combination of donazepam and memantine, which is an MDA receptor antagonist, can be considered. We also with the same aim to improve the condition. Next is for the dementia of Lewy body. The recommendation drug would be the rivastigmine. However, there is no approved treatment available for frontotemporal dementia syndrome, as the mechanism of action of the drug gradually works on frontotemporal dementia, as it has a different pathophysiology than the other kind of dementia, in which cholinergic neurons are relatively preserved in the frontotemporal dementia. And in addition, patients who are on this cognitive enhancer should be reviewed at least once every 6 months by using the psychometric measurement, for instance, the mini-mental state examination, to monitor the improvement and respond to the treatment. The next slide. Lastly is the measurement for the behavioral and psychological symptoms of dementia. It is a common presentation in people with dementia, in which it includes the symptoms or signs of agitation, psychosis, and aggression. Even though psychological intervention is the first line therapy, however, drugs such as antipsychotic can be considered if symptoms are distressing and other treatment has failed. However, this should be avoided in dementia of Lewy body, and this indication also applies with comorbid emotional disorders such as depression and anxiety, in which it can be considered we can they can be considered to be given antidepressant, and anxiety if symptoms are severe and distressing to the patient and also the caregiver. So that's all for me. Thank you. That's all from us.
Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Thank you very much for the presenters. I'm just gonna try and respond to several questions and comments that has been shared over at menti.com. You can still continue to ask, comment, or suggest that, no problem. Probably take around 30 minutes of your time. Okay, the questions that are Googleable, I might not want to explain in detail. All right, these are facts and we can find them at most references, but I'll just try to shortly answer you because we understand that in the field of medicine, especially in psychiatry, it's very vast, very broad. There's no one answer if you ask me, okay? And most of the things it sometimes has to be looked into certain contexts. Here, for instance, if the question is, contohlah, is suicidality more common in women? You know, it's going to be hard to answer because you will need to have a lot of information of data from not just local population but also across the globe, and you're not going to get one answer, either it's yes or no. Okay, so it's kind of like difficult in that sense. So I'll try my best. Now, okay, can we prevent dementia? Okay, can we prevent dementia? From my experience, from my understanding, I can only say that we can reduce the likelihood of it occurring. Okay, there's no guarantee 100%. We can reduce the likelihood, and one of it is by always accessing or activating our cognitive functions. All right, means by reading, by solving problems, good sleep, good nutrition, good diet, exercise, all those kind of things. So I won't say that we can prevent dementia, but we can reduce the likelihood of it occurring. Okay, and there are many references that you can see elsewhere. Next question is, in DSM-5 delirium, for point B, what does it mean by tends to fluctuate in severity during the course of the day? Okay, so this is probably from a literal point of view. Tends to fluctuate severity ni, okay, if any of you yang mungkin tak jelas bahasa Inggeris ataupun tak faham bahasa Melayu, I try to use both languages. Kalau tak faham juga, you can just ask me for further detail of the situation or explanation. I'll try my best. Now, tends to fluctuate ni maksudnya it would be more likely to fluctuate. Fluctuate ni, if you understand, it means that it goes up and down. It goes up and down, and in severity. So sebagai contoh, a patient who is in the medical ward, 35 years old, male, married, okay, so he's in a delirious state. Okay, delirium ni ada I think your colleague dah share tadi, ada hyperactive state, ada hyperactive state, ada mixed state. So contohnya kita ambil hyperactive. Hyperactive maksudnya kita nampak dia, we can see the person in distress, we can see the person is confused. Okay. So what happens in fluctuation means that at 8 a.m. he appears to be confused. At 10, he's okay. 12, confused again. 2 p.m. okay, and then confused again, it goes up and down. And worse time is usually during what we call sundowning, or bila dah nak senja, when it's almost Maghrib. This is where the patient becomes really agitated, really confused, maybe have hallucination and whatnot, and delusions. And this is where they become severely affected by delirium. And perhaps by 10 p.m. they'll be okay, tomorrow morning pun okay, not fully okay, but not as bad as it was during that Maghrib time. This is what we call tends to fluctuate. And this is important to differentiate from dementia, whereby dementia, we normally generally see the condition in patients who are 60, 65 years old and above, okay? But dementia, they would not have that fluctuation. And dementia, normally we would talk about, normally we would talk largely about memory impairment or memory decline. That's the biggest bulk of dementia. The meaning it is memory. Okay, so if you compare yang 35 tahun tadi tu dengan a 65-year-old gentleman, both would have probably memory impairment, because when you ask questions about things that will assess memory, both cannot answer, because the delirious patient probably has no attention locked in. They also doesn't have any concentration. They are confused. Patients with dementia, they might have attention. They might seem to be more focused. They're not confused, but their memory is not intact. Whether that's recent memory or that's remote memory, it depends on the severity of the condition. So meaning to say that for that 65-year-old gentleman who has memory decline, okay, it does not fluctuate. If he didn't remember yesterday, he's not going to remember today, and he's not going to remember tomorrow. Ask the same question also, he's not going to remember, and this thing is seen to be in decline throughout the weeks, throughout the months, throughout the years. For dementia, mentioned earlier on, it's gradual and progressive. It's something like renal impairment, the ones that are leading towards end-stage renal failure. You can't stop the impairment. You can only retard it by using medications, by not causing any further injury to the renal tubules. Okay, more or less like dementia. You can't stop dementia when it has occurred, but you can retard it by using medications or any other non-pharmacological measures, I think mentioned in the last few slides. Okay, so to understand this question, Nanti I'll just share a slide. It's also on the internet, the differences between delirium and dementia, and these differences are always tested in MCQ, OBA, and also PMP. The differences you must know. If you still don't understand, it's okay. You can always contact me, and I'll try to help you as best as possible. Okay. Does dementia equal to nyanyok? I would say yes. Again, it depends on local population. It depends on local population, what terms that they use. And I understand that in the Malay culture or Malay language users, nyanyok ni would mean that there's memory impairment. You can use that. Memory impairment in old people. You don't use nyanyok in younger people. So yes, dementia is equal to nyanyok. Delirium dementia a symptom or a diagnosis? Good question. If it is in DSM-5, then it's a diagnosis. Is delirium in DSM-5? You can find out. Is dementia in DSM-5? You can also find out. The question is, are we still using the term dementia in DSM-5, or have we changed it to cognitive impairment or other terms? Okay, so the terms might change, but the characteristics may remain the same. Macam rebranding lah. Import kereta, apa kereta apa tu? Mitsubishi apa tu? Apa dah? Inspira tu asalnya apa? Mitsubishi apa? Mitsubishi. Yes, sorry. Import Mitsubishi Lancer sampai kat Malaysia, tukar sikit jadi Inspira. It's the same criteria, more or less, but they just change the name. Okay, so you might not find dementia in DSM-5, but you will see it in a different form. But it's it's under the neurocognitive disorders or impairment. Okay, all right. Usually nyanyok we refer to dementia or Alzheimer's. Okay, now dementia, if you understand, if you can imagine an umbrella, huge umbrella. Okay, so you open the umbrella is dementia, and below it is Alzheimer's, is Lewy bodies, is vascular dementia and whatnot. So dementia is a collective term yang besar, and below it are the different types of dementia. So Alzheimer's is a subtype of a dementia. Okay. Could you please give a simple case scenario so I could better understand the difference between delirium and dementia? I think I've given early on tadi. If you need more, I'll do so. All right. I'll just cover the rest of the questions first. Which types of dementia has poorer prognosis? There's a lot of dementia has poorer prognosis. I think this is also Googleable, but among it is frontotemporal dementia. I hope other slides that was done. What is impaired consciousness? Is it the same with drowsiness and stupor? Okay. First of all, we must understand what is consciousness. And consciousness is if you book out reference, you book out 10 references, maybe they have 5 or 6 different ways of defining what consciousness is. That's normal lah tu. Okay. But you want to know what are the core features of consciousness. Okay, as far as definitions, when you go to different dictionaries are concerned, they will say that consciousness is a state of being aware and responsive of one's surroundings. And you have to be aware. Like now we are aware of our surrounding, we respond to our surrounding. That's awareness in basic terms. Some also say that awareness is also similar to perception of something. So it depends what references that you're referring to. In this case, is consciousness the same with drowsiness and stupor? I would probably advise you to, what I normally do is that what I normally do is I go to maybe 5 different sources, how they define consciousness, okay? And then I go to also different sources, how they define drowsiness and stupor, and then you can see the differences from there. You know, to me in medicine, kadang-kadang ni bukan is black and white lah. In medicine, kadang-kadang it is an art. You know, it depends on how we put things into context. So I cannot reply black and white here. I can, but then there will be other options as well. You know, there are other explanations as well. So that might not be covered in one simple explanation. Okay. So if you say in general terms, if you say is impact consciousness same with drowsiness stupor, I would probably say yes, but then they would syarah yang panjang sikit lah. Okay. But for simple understanding for layman people, I would say yes. Okay. All right. Can memory impairment be treated? Memory impairment would depend on number one, what is the definition of memory impairment? Number one, what is the working definition? Because if you do different studies, memory impairment will be defined differently. For instance, I would say, I'll just give you a simple example first. Katalah kita katakan, simple example, very super simple example, nasi lemak. We say nasi lemak. Of course, we would have to define what is nasi lemak. Okay. In general terms, it would have nasi, it would have rice, it would have sambal, it would have telur and ikan bilis and kacang timun and whatnot lah. You know. But then the nasi lemak would differ in terms of the taste, the temperature, cara dia bungkus apa semua. So when you do a study, contoh on nasi lemak, we would have to define, okay, nasi lemak means dia santan banyak ni, nasi banyak ni, you know, dibalut dengan daun pisang, kacang banyak ni, rapuh dan sebagainya, blah, 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 right? Then only we can compare. Okay, then only we can comment for that context. Kejap, I need to pick up this call, I don't know who. Hello? Yeah. Siapa tu? Oh ya. Okay, sekejap. Saya dengan dia force sekejap. Nanti dia 9:30. Nanti WhatsApp saya dia punya link tu boleh? Okay, thanks. Hello? Ya, salam. Ya. Ya, saya. Ya. Saya ada kelas. Kemudian boleh? So, minta message. WhatsApp saya. Okay, thanks. No problem. Bye-bye. Sorry, I forgot I have class at 9 with year 5. Okay, where were we? Nasi lemak, yeah, okay. So we will have to define what memory impairment is because we know memory impairment ni ada short term, ada recent memory, or also the remote memory. So if we talk about remote memory is stored in the cortices, so that would be almost impossible to treat lah, or to install balik in that sense. So it depends. Can memory impairment be treated? Again, it depends on what kind of memory is involved. Okay. Next one is, can we petition the exam to be on Friday? This one you can discuss with the jabatan or can inform by the ideal. Okay, can inform him. He will relay this information to the other specialists and also the HR department. Does a delirium person usually feel depressed or sad with his own incapability? Do they realize it? Okay, delirium ni, if you can imagine, dia macam very short burst of confusion. So if you ask me, they won't have time to have that depressed feeling as macam someone who has major depressive disorder lah. Okay, because delirium tu, they are not aware of their surrounding most of the time. Okay, during the episode. So I would say no. Right. What's the most common type of dementia? Okay, you can Google this, but in short, yang selalu keluar exam, most common is Alzheimer's or dementia of Alzheimer's type. Second one is vascular dementia. Selalu keluar exam. So you want to know about these two things, in and out. Basically, the slides pun dah cukup dah for you to get a grasp of how to diagnose a person who is having Alzheimer's as opposed to vascular dementia and vice versa. Okay, jot down in your notes. Kita selalu tanya about the progression of the condition. Number one is the stepwise progression. The other one is gradual decline. The gradual decline is in the Alzheimer's, and stepwise is in the vascular dementia. Selalu keluar exams, and if you want to know more, read more, and then you can ask me later. Can a person have delirium with unknown cause? Okay, kalau ada unknown cause, then it is unlikely to be delirium, because delirium, as far as the criteria is concerned, you would have to have a demonstrable biological investigation result to say that, oh, this is due to delirium. This is causing the delirium. Okay. One last question. How delirium causes mortality in patients? Is it because they hurt themselves? How delirium causes mortality in patients? Okay. And why delirium occurs among surgical patients? Is it because of age, or somehow due to surgery? Is there disturbance in neurotransmitter resulting in delirium? Okay, good question. Now, delirium, we know it is because of biological disturbances, whether that be in the blood, whether it be in the urine, whether it be in the brain, you know, and whether that be neurotransmitter, everything is just a cascade of things happening. So sometimes when we want to discuss what causes which, it's very, very difficult to find the exact cause. I mean, in terms of micropathology ataupun deep down inside nak tahu, oh, this is the reason. It's very, very difficult. For instance, there'll be this old person who presents to the surgical ward with delirium, with distended abdomen or distended bladder. Okay, then you empty the bladder, and the symptoms of delirium goes away. Similar patient, old patient, distended abdomen, but extracting all the impacted feces. Then you do the necessary. That includes manual evacuation. And when he's able to pass motion, he's normal again. All right. So punca delirium tu we know, right? But to pinpoint to specific things, we don't know lah. Atau we cannot be for sure. It is the association we can find. And dalam medical banyak kita guna association with, especially in psychiatry lah, because we cannot find the cause, or we cannot demonstrate the cause. Contoh, what causes schizophrenia? Nobody knows. You know, you can associate with certain genes, you can associate it with drugs, you can associate it with social stressors and whatnot, but you know, we cannot pinpoint the cause. So we can try to find association, but to mention the cause something is difficult. Same thing. If we say, I think this is used so many times, when we ask, does smoking cause cancer? You know, is it a yes or no? If smoking does cause cancer, kenapa ada yang isap rokok tak dapat cancer? Right? If you don't smoke, do you get cancer? Nobody can say yes or no, because ada yang tak serokok still dapat lung cancer, which is similar to those who smoke. Okay, so we can only say, or it's only appropriate for us to say that smoking is highly associated with lung cancer, and define the types. Like we can say highly associated, poorly associated, low association. We can use those kind of terms. All right. Last question that I have here is the if we know we have the genetic of dementia, is there any way to prevent having dementia? Again, I think not prevent dementia is uncertain, I would say. We never know, but we can try. But we can reduce the likelihood or the possibility of getting dementia by, again, makan minum yang sehat, exercise, reading a lot, and doa, of course. In psychiatry, we like to use the biopsychosocial and spiritual approach. Okay, biology jangan introduce toxins to the brain. Psychology have more of a positive psychology, if I can say so. Sokongan sosial daripada keluarga, rakan-rakan, pasangan dan sebagainya, dan juga kerohanian. These are all important for us to reduce or mitigate the risk of getting any disorders or illnesses. That's all I can say. All right. So I'm so sorry I have to go now to the next class. I really appreciate the presenters. Thank you very much to all the presenters. Lovely slides, by the way, and lovely poster. You can still ask questions, no problem. You can kumpulkan soalan bagi the presenters, and I'll try to compile, and at half time I'll try to reply as fast as possible. With that, I think we have to stop here and, thank you very much. And back to you, Mr. Madam Pengurusi. Thank you.
Right. Thank you, Doctor. So we close our session today with Tasbih Kapara and Surah Al-As. Thank you, everyone.
Thank you, Doctor.
Thank you.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you.
Thank you, Doctor.
All right. Thank you.
Thank you,